Hello everybody, this is Dr. Tilak from the Department of General Medicine, Medicity. Today I'll be discussing another important topic from neurology, and that is disorders of the peripheral nerves, peripheral neuropathy. And this type of disorder we see all every day, and you will see such disease everywhere, whether you are working in the small center or referral centers. So, neurological disorders affecting the peripheral nervous systems are quite common clinical disorders. So, whenever there is involvement of peripheral nerves, it may affect the any type of nerve, motor nerve, sensory nerve, autonomic nerves, singly or in any combination. The causes of these peripheral neuropathies are wide. Various types of disease may be there. It may be inherited disorders, acquired disorders, inflammatory conditions, infections, drugs. So many types of etiology can cause dysfunction of the peripheral nerves. So as the etiology is different, so will be the clinical presentation. So clinical presentation, because of peripheral neuropathies, is highly variable from individual to individual. So these are the different conditions which can affect the peripheral nerves. It may be some pressure on the peripheral nerves, like entrapment may be there. For example, a median nerve get compressed at the wrist, causing carpal tunnel syndrome. Or sometimes the nerve may get trapped at the knee and affecting the common peroneal nerves. Similarly, elsewhere. And other conditions are systemic disease. The systemic disease may be inflammatory conditions like lupus or rheumatoid. It may be malignancy, or maybe other autoimmune disorders, or it may be infections. Sometimes ischemic changes can also affect the peripheral nerves. Whenever there is a peripheral vascular disease that can cause decreased blood supply to the nerves, that may cause ischemic injury. Sometimes malignancy somewhere can affect the peripheral nerves at a distant place through autoantibodies. Sometimes it may be some nutritional disorders which may cause peripheral neuropathy, like vitamin B1 deficiency, vitamin B12 deficiency, etc. Infections like leprosy can also affect the peripheral nerves, and various kinds of toxins. It may be some pesticides, insecticides, it may be lead, etc. They may affect the peripheral nerves. So whenever a patient has got peripheral neuropathy, when we approach how to find out the type of disease, severity of the disease, or etiology of the disease, we don't have to do all sorts of investigation in every patient of neuropathy, because the etiology will be different. If we end up doing all sorts of tests, it will be unnecessary wastage of resources. So first you should take the history about the possible nerve involvement and about the possible etiology. Then you examine the patient. Examination will tell you which nerves are affected, so that you can direct the investigation to that part of the nervous system. And subsequently, you can do the electrodiagnostic study to find out whether the nerve is really involved or not, what is the severity, whether it is axonal or demyelinating type of disease. Subsequently, you can do some other supportive investigations based on the previous evaluation. So it may be a case of suspected collagen vascular disorders, or it may be a case of some infection like leprosy. So based on that clinical profile, you have to carry out other investigations. It may be some autoantibody evaluation or some biopsy, etc. So approach should be logical, based on the history, based on examination, and based on nerve conduction or electrodiagnostic evaluation. So it will decrease the chances of or the possibilities of the nerves which are affected by the disease, and which investigations are to be done. You don't have to do all the investigations in every patient. So based on this, you have to shorten the list of differential diagnosis and etiologies. So then you can find out whether all this can be evaluated or found out based on which type of fibers are affected, like whether the patient has got motor involvement or sensory involvement or autonomic involvement, and what is the pattern. Is it involving the distal nerves only, or proximal nerves only, or multiple nerves only, and what is the course, whether it is progressive or remitting and relapsing. So that will give you some idea about the type of the nerve involvement and severity and possible etiology. So whenever there is an injury to the nerve, whatever the etiology, whether it is some entrapment or vasculitis or toxin, etc., what happens to the nerve pathologically? Pathologically, there may be degeneration of the axon, which is called Wallerian degeneration. So whenever there is some injury, that part of the nerve will get damaged, and subsequently the proximal and distal part also may undergo degeneration. That is called Wallerian degeneration and also called axonopathy. Sometimes it is not the nerve, but it is the primary cell of the neuron, what is called pericardial. If that is damaged because of some disease process, might have some ischemia is there, and it is or motor neuron disease is there, and that is affecting the neuron either in the spinal cord or elsewhere, and because of the loss of the neuron cell body, the axons connected to the neuron will undergo degeneration. Sometimes the pathological reaction in the nerve may be in the form of demyelination, which may be widespread or segmental. So what happens in Wallerian degeneration? If this is the nerve, and this is the central part is the green is the axon. Suppose there is some injury to the nerve. So what will happen? So distal part of the axon is basically not in continuity with the proximal part of this neuron. So this part axon will undergo degeneration, but the myelin sheath may remain intact. So axon will undergo degeneration. This is called Wallerian degeneration. So whenever there is a Wallerian degeneration, what happens? The axon is damaged. Because of that, if you do a nerve conduction study or electrodiagnostic studies, in that the amplitude of the nerve potential or motor action potential or sensory nerve action potential will be severely reduced. But it takes few days. It does not come on the day of the injury. So after the injury to the nerve axon, the amplitude of the potential on nerve conduction study will be decreased after few days. It may take 1 or 2 days after the injury, and subsequently this reduction in amplitude will become more severe, and it may reach its maximum reduction in over 7 days or 1 week period. And same thing will be there in the reduction of the sensory nerve action potential, but it takes a little extra time compared to motor action potential. So here the problem in SNAP, basically the sensory nerve action potential will reduce by about 3 days of following injury, and subsequently it will reach its maximum severity of reduction in amplitude by about 11 days. And if you do the nerve needle electromyography, it will show features of denervation in the affected muscles. Sometimes the axonal lesions or axonopathy will have a phenomenon which is called dying back or length dependent pattern. What happens if there is some injury to the nerve or axon? It will start distally. For example, in the lower limb, the problem will start in the distal most part of the nerve. Suppose there is a sciatic nerve coming from above, then it divides into common peroneal, then it will come down and a part of the sural nerve. So the distal most part of the nerve will be affected first, like at the foot, then at ankle, then it will progress proximally. Then it will reach the knee level, and then it may affect the upper limb also. It's basically dying back phenomena or length dependent pattern of nerve loss because of axonopathy. So it is called stocking like pattern. So basically in this waterfall, first the sensory loss will happen around the toes, then around the ankle, and then around the leg, and then proximally it will proceed. So this is called stocking type of sensory loss. Similarly, in that area, whatever the muscles are there which are supplied by the nerve distally, those muscles will become weak, and the patient will have muscle weakness and also loss of deep tendon reflexes. So same process will once this dying back phenomena reaches the level of the knee, then it will start affecting the upper limb also. Basically, it depends upon the length of the nerve. Longer the nerve, earlier will be the involvement by the peripheral neuropathy, and subsequently the proximal part of the nerve or shorter nerves will be affected. So it happens in peripheral neuropathy. The problem will, the sensory and motor deficit will start distally from the toes, then ankle. It will reach till the knee. By the time it reaches knee, the problem will start in the finger also, and then by the time the sensory loss or motor loss in the lower limb reach the mid thigh, it will also progress proximally in the upper limb, and subsequently the intercostal nerves will also be affected. So there may be some sensory and motor loss in the central part of the abdomen, and later on the recurrent laryngeal nerve will also be affected because it is also quite long. So second type of pathological reaction which may occur in patients who have got peripheral nerve involvement because of some disease process is loss of myelin sheath around the nerve fibers, or demyelination or myelinopathy. So this demyelination may occur by various mechanisms. One is the mechanical. If the nerve is pressed continuously or intermittently again and again, there may be loss of myelin. Or sometimes the myelin is lost because of some immune reaction, like as may occur in various demyelinated disorders like Guillain-Barré syndrome is there. Or sometimes the myelin is lost because of some congenital or hereditary disorders, like we have a hereditary sensory motor neuropathy or Charcot-Marie-Tooth disease. In demyelinating type of disorders, what happens? Only the external myelin sheath is affected by the disease process, but the inner part of the nerve, the axon, remains intact. As a result, the muscle atrophy will not be there. The weakness may occur, but the atrophy will not occur. And because the fibers which carry temperature and pain, they are very small fibers, they have got either no myelin or very thin myelin, they are not affected by the demyelinating disorders as much as the other fibers. So if a patient has got peripheral neuropathy, we do not know whether it is axonal neuropathy or demyelinating neuropathy. So from the clinical examination itself, we can find out whether it is more likely to be axonal neuropathy or demyelinating type of neuropathy. So if a patient has got some neurological problem in the peripheral nervous system and the reflexes are lost early, but the muscle atrophy is not prominent, then it goes in favor of demyelination. In case of axonopathy, the muscle wasting is more prominent. Okay, and at the same time, patient may have some additional features, like there may be some tremors, or sometimes because of demyelination, remyelination, and again demyelination, there may be an enlargement of the peripheral nerves. So these things are suggestive of demyelination, not axonopathy. So if you do some diagnostic evaluation of patients who have got demyelination of the peripheral nerves, then what are the findings? So if you do electrodiagnostic evaluation like nerve conduction velocity, because of demyelination, there will be significant reduction in the nerve conduction velocity. So nerve conduction velocity in these patients will be less than 70% of the normal. But because the axon, the inner part of the nerve is normal, the amplitude of the compound muscle action potential and sensory nerve action potential will be relatively preserved. The velocity is predominantly affected. The amplitude of the potential is affected little bit. Sometimes there may be some conduction block also, and also there will be temporal dispersion, which means whatever the duration of the action potential is there normally, this duration will be more than normal, and the distal latencies or F-wave latencies will be prolonged whenever there is demyelination. So peripheral nerve disorders can be classified differently according to the type of nerve involved, according to the type of location of the nerves involved, according to the symmetry or asymmetry. Sometimes the neuropathy is affecting only one nerve, nothing else. This is called mononeuropathy. Sometimes it is not the distal nerves but the proximal part of the peripheral nervous system, or called plexopathy. It may be related to the upper limb or the lower limb, or sometimes it is only the even proximal to the plexus. Radicals coming out of the spinal cord may be affected by various disease process. It may be degenerative process like spondylosis. It may be some tumor near the spinal cord. So that is called radiculopathy. Sometimes what happens, a patient has got one nerve involvement at one side and another nerve involvement elsewhere. So previously it was called mononeuritis multiplex, but now this term is not used. It is called multiple mononeuropathy. And another pattern of nerve involvement may be polyneuropathy, which means multiple nerves are affected. Mostly polyneuropathy simply means the nerve involvement is starting from the distal part of the body, lower limb then upper limb. Mostly it is symmetrical, but sometimes it may be asymmetrical. Sometimes both the peripheral nerves and radicals may be affected, called polyradiculoneuropathy. So coming to one type of neuropathy, mononeuropathy. As the name suggests, in this only one nerve is affected, all other nerves are normal. So what will happen? So whichever nerve is affected by the disease process, only the manifestations will be in the territory of that nerve because of a local process affecting the nerve. So this may be mostly because of some local pathology. It may be some direct trauma. It may be some small vascular lesion, maybe a particular artery is blocked by some vascular lesion, or maybe a tumor has infiltrated there. So basically it's a local process or pathology which is affecting only one nerve. And if you do the electrodiagnostic evaluation, it will confirm that the nerve is definitely affected and what is the precise location, proximal, distal, and which nerve is actually affected by the disease process. So this mononeuropathy can affect any nerve depending upon the underlying etiology. It may affect the median nerve, it may affect the radial nerve, it may affect common peroneal nerve or any other nerve. So when only one nerve is affected, this is called mononeuropathy, and the manifestation, sensory, motor, etc. will be in the territory of that particular nerve only, and the rest of the nervous system will be normal. So coming to multiple mononeuropathy, previously called mononeuritis multiplex. It basically means one nerve at one side is affected and another nerve is affected elsewhere. So they may get affected at the same time or one after the other. So basically it may be simultaneous involvement of the different nerves or sequential. Okay, so basically it can affect any nerves, upper limb, lower limb, or cervical region or thoracic region, etc. Sometimes neurological deficit will be patchy. Maybe right hand is affected or left foot is affected or the radial nerve is affected or facial nerve is affected. So there will be different sites of patchy involvement. But sometimes this multiple mononeuropathy may affect the adjacent nerves also. It may look like a distal symmetrical polyneuropathy type picture. Here it is a case of multiple mononeuropathy. Here what is there's something happening in the right upper limb. Okay, at the same time something happening in the right common peroneal nerve region, or basically sural nerve region, and something happened the common peroneal on the left side. So these are basically non-contiguous nerves and are affecting different parts of the peripheral nervous system at the same time or in sequence. This is an example of multiple mononeuropathy, previously called mononeuritis multiplex. So polyneuropathy, as the name says, when multiple nerves are affected, it's called polyneuropathy. Mostly it is bilateral symmetrical. Sometimes it may be asymmetrical. And mostly it starts from the lower limb, then it progresses proximally, then affects the upper limb as well. So mostly it is symmetrical and it starts distally, then it progresses in a graded fashion proximally. So it basically depends upon the length. So longer the nerve, that will be affected first, and subsequently the proximal part of that nerve will be affected, and subsequently the smaller nerves will also get affected. So mostly it is symmetrical, rarely asymmetrical. So as I mentioned here, in polyneuropathy, the longest nerve is the nerve which is reaching the toes. Okay, so the problem will start distally. So patient will have some sensory manifestation. It may be positive or negative sensory manifestation, and the patient will also have motor problem. Some motor weakness will go, and this neurodeficit will progress gradually up to the knee. Till that time, no other part is affected, and by the time it reaches knee, this upper limb nerves are also quite long, so little bit less long as compared to the lower limb. So by the time the peripheral nerves are affecting the lower limb muscles and the deficit reaches the knee, there is involvement in the upper limb also distally. Then it also progresses proximally, and subsequently the intercostal nerves, which are also relatively long only, they get affected, and later on the recurrent laryngeal nerve will be affected. So the neurological manifestation, sensory motor will start from the toe, reach the ankle, reach the knee, then the hand, and then it will affect the anterior part of the thorax and also subsequently the larynx. So from the history itself you can find out clues in favor of involvement of the peripheral nervous system. So what are those clues? So whenever a patient has got some peripheral nervous system involvement, the patient will have symptoms because of the nerve involvement. The symptoms may be negative and positive. So what the meaning of the negative is, there's some loss of the nerve function is there. The loss of nerve function may be muscle motor loss, so the patient will have some weakness, atrophy or fasciculation, and then it will result in various difficulties, difficulty in walking, difficulty in wearing footwears or holding something in the hand also. And positive motor manifestations, patient may have some fasciculations or cramps or myoclonus tremor. They are positive motor manifestations coming from nerve involvement. Similarly, the patient may have other manifestations which you can elicit in the history. So negative motor symptom, you can ask whether there is any difficulty in wearing the chappals or holding something in the hand, etc. or not. That will be suggestive of weakness distally. Similarly, the patient may have some clues about the sensory manifestation because of involvement of the peripheral nerves. So sensory manifestation again may be positive sensory manifestation and negative sensory manifestation. So peripheral nerve, sensory nerve involvement will give abnormal positive manifestations like some pricking sensation or numbness. They will use various terms, numb, pricking or some burning sensation. They are positive manifestations, sensory. Sometimes there may be negative sensory manifestation in the history. So patient may give history that there is loss of touch, loss of temperature sensation, etc. And because of involvement of the nerves which carry sensation from the tendon, muscle and the joint, the patient may have some gait abnormality because of sensory ataxia. Other things you can elicit from the history is whether the patient has got some other manifestations like autonomic involvement. In peripheral nervous system involvement, autonomic manifestations may also come. So there may be some postural hypotension, or abnormal sweating may be there, or heat intolerance may be there, or some other autonomic dysfunction of the viscera may be there, blood bowel dysfunction, etc. or GI dysfunctions may come because of involvement of the autonomic nervous system. So when you take the history will give you idea when the process actually started. So duration you will know whether it is few weeks or few months, etc. That also gives some idea about the type of the pathology or underlying etiology and how the manifestations evolved over a period of time. All these will give you clue about the underlying etiology and the type of pathology. So sometimes peripheral nervous system involvement may be acute. So the onset and progression is very important. You should find out from the history. So acute presentation is quite often seen in conditions like Guillain-Barré syndrome. Patient may be absolutely okay day before and suddenly the patient may have motor manifestations, sometimes motor plus sensory and autonomic manifestations also. So it may be acute manifestations of peripheral nerve involvement may be seen in GBS, acute porphyria or vasculitis or neurological amyotrophy like in diabetic patients. Sometimes because of toxin, patient may have consumed some poison and within few days the patient may have a peripheral nervous system manifestation like you may see in organophosphorus. Even in lead poisoning also acutely you may have some manifestations. Other cases may have manifestation and they will improve and again the manifestation may come back. So patient may have relapsing remitting type of course of peripheral nerve involvement. It is seen in various conditions like CIDP. In GBS it is only one time and sudden onset. In CIDP it is recurrent, may come again and again. Acute porphyria can cause neuropathy and there may be improvement and again it may come back. There may be some other inherited disorders like Refsum disease or maybe some hereditary neuropathy. Or sometimes some brachial plexopathy may occur because of familial reasons. So here the patient may have repeated episodes of nervous system dysfunction in the periphery. In other cases, the patient may have involvement of the peripheral nerves and it starts and it keeps on progressing very slowly over a period of several years or even decades. So whenever you have this type of chronic indolent course, then you should think of some inherited disorders. Like you have got hereditary sensory motor neuropathy, which is called Charcot-Marie-Tooth disease. So whenever you have this type of disease, you should think of some inherited or congenital disorders affecting the peripheral nervous system. Sometimes what happens, it is not the disease which is affecting the peripheral nervous system primarily. Patient may have some systemic disorders and that may affect the peripheral nerves in later on. So these systemic disorders may be various types. It may be some nutritional dysfunction may be there, like vitamin B12 deficiency or B1 deficiency. It may be some autoimmune disorders like lupus or rheumatoid arthritis. It may be some malignancy, and they may affect the peripheral nervous system. So whenever a patient has got systemic disorders causing peripheral nervous system dysfunction, there will be some presence of some constitutional features. So patient may have some problem related to weight, or some appetite may be less, some fever may be there, and other features of the other disorders, which is primarily affecting the body. So whenever patient has got a peripheral nervous system, you should always find out from the history whether the patient has got some comorbid condition or not. It may be some metabolic disorder like diabetes mellitus, which is very common, and it affects the peripheral nerves quite often. It may be other dysfunction of the thyroid gland, or the dysfunction of the kidney, liver, etc., or intestine. If the intestinal dysfunction is there, there may be malabsorption that may lead to deficiency of various nutrients. Sometimes malignancy can affect the peripheral nervous system through metastasis or through paraneoplastic syndrome, and some infections or autoimmune disorders can affect the peripheral nervous system. And also you should take the history, whether there is any evidence in the history of exposure to some drugs or toxins, etc. So, because sometimes the patient may take alcohol, patient may be having some exposure to heavy metals because of industrial reason or because of some other reasons, or there may be some excessive dose of vitamin also. Vitamins are not safe all the time. Deficiency of B12 can cause neuropathy. Similarly, excess dose of B6 can cause neuropathy. So you should take history of drugs, history of any addiction, history of exposure to toxins. And when you examine the patient, find out what the pattern is and which particular nerve is affected. All the nerves are not affected. It may be upper limb, it may be lower limb, or something else. So you should find out pattern and which nerve is affected, and what are the type of deficit. Whether the patient has got only motor deficit, sensory deficit, or autonomic manifestations. So that also will give you about the type of the etiology. So as I mentioned, mononeuropathy basically involvement of one nerve. So clinical features will be limited in the territory of that nerve, and rest of the body will be normal. Okay. For example, suppose a patient has got common peroneal nerve involvement. So there will be motor manifestation affecting the foot, or sensory manifestation affecting the lateral part of the leg and dorsal part of the foot, and rest of the body will be normal. If a patient has got radial nerve involvement, so manifestation will be in the territory of the radial nerve. It may be sensory manifestation on the outer part of the arm and the dorsal aspect of the hand. And there may be motor involvement, mostly of the extensor muscles of the forearm. Sometimes there may be involvement of the median nerve at the wrist, what is called carpal tunnel syndrome. So manifestation will be in the territory of the, or distribution of the median nerve only. So these are examples of mononeuropathy. Sometimes patient may have multiple nerve involvement at different places. They are not contiguous nerve involvement. One nerve may be in the upper limb, one may be in the lower limb, one may be in the cervical region. So this is called multiple mononeuropathy. Like here, the forearm and dorsum of the hand is affected. Here, the lateral aspect of the foot is affected. Here, the lateral and mid entry part of the leg is affected. So the different nerves are affected sequentially or at the same time, and which are not contiguous. So these are examples of the multiple mononeuropathy. So clinical manifestation will be in the distribution of the individual nerves in the upper limb, right lower limb, left lower limb, etc. So there are various conditions which can affect multiple nerves either sequentially or at the same time. It may be an injury to the axon, it may be injury to the myelin sheath only. So injury to the axon may be because of conditions like vasculitis, or infiltrative disorders, or metabolic disorders like diabetes, or sometimes infection. And demyelination at multiple sites may occur because of multifocal motor neuropathy, or sometimes other types of, this is basically Lewis-Summer syndrome is a type of CIDP only. Sometimes it may be some metabolic disorders like diabetes also causing only demyelination. So if a patient has got multiple nerve involvement, which is called polyneuropathy, and mostly it is bilateral symmetrical starting from the distal part of the body. So usual manifestation will be same. So patient will have manifestations because of involvement of the nerves which is length dependent, which means the longest nerve will be affected first and subsequently shorter nerves will be affected. So the manifestation will start from the lower part of the body, from the toes, that will go to the leg and knee, subsequently the upper limb, and subsequently the trunk will be affected. So basically the shorter nerves are affected later and longer nerves are affected in the beginning. This is called glove and stocking pattern, both sensory and involved and motor. And other condition is called polyradiculoneuropathy, in which the peripheral nerves are affected by the disease process and the proximal part of the peripheral nerves, which is the part of the nerves coming out of the spinal cord. So manifestation will be according to the radicals involved. So in that, what happens, because the radicals are affected, so proximal manifestations are quite significant or severe. So the patient will have proximal muscle weakness because of the involvement of radicals, and maybe even distal nerve involvement, muscle involvement because of the peripheral nerve involvement. So this type of manifestation where the distal and proximal muscles are affected at the same time, or maybe or to the same severity, you should think of involvement of both the peripheral nerves and also the radicals. So it may be seen in various conditions like demyelinating disorders, like CIDP is there. Sometimes it may be because of systemic disorders like myeloma or porphyria. And sometimes the diabetes may affect not just the peripheral nerves, but may affect the proximal part of the peripheral nervous system, that is plexus or radicals. So basically it is just like the sensory manifestation, the motor manifestations in polyneuropathy starts from the distal part of the body, that is toe, then ankle, then knee, then the upper limb. So just like the sensory manifestations. So whenever the polyneuropathy is there, it affects both the sensory fibers and motor fibers. So patient will have motor deficit and sensory deficit. But sometimes what happens, certain neuropathies which cause polyneuropathy, only the motor manifestations are there, or mostly motor manifestations are there. Sensory manifestations may be negligible. So polyneuropathy affecting only the motor fibers may be seen in conditions like multifocal motor neuropathy, or sometimes it is acute axonal neuropathy, which is type of GBS only. Or usual GBS can also have that type of manifestation where only the motor nerves are affected. Sometimes it may be CIDP, in which not sensory but only motor manifestations are there. So they are basically different examples of predominantly motor polyneuropathy. It may be because of toxins also, like lead. So whenever this polyneuropathy, as I mentioned, it is dependent, it is a basically length dependent polyneuropathy, which means the longest fibers affected first and smaller fibers affected later, which means the problem will start from the toes, then ankle, then knee, and then the hand, in that way. So basically polyneuropathy starts distally. It affects the legs more severely than the arms or upper limb. But sometimes there may be exceptions. So what happens, sometimes in polyneuropathy it is not the lower limb but the upper limb which is affected more than lower limb. So these are the situations where the upper limb involvement is more severe in polyneuropathy, like multifocal motor neuropathy, or a variant of CIDP which is called Lewis-Summer. So, and in lead poisoning also the upper limb is affected more. Porphyria is also upper limb is affected more. So there are some examples where the polyneuropathy affects the upper limb more than the lower limb. So in what happens, polyneuropathy, there is involvement of the sensory fibers, motor fibers, and autonomic fibers. Mostly there is a combination. Sometimes it may be predominantly motor, or it may be predominantly sensory, or maybe only autonomic. So they are the different types of polyneuropathies. So patient with the polyneuropathy having autonomic dysfunction may be seen in maybe having conditions like, it may be acute onset. So a patient who has got peripheral nerve involvement with autonomic dysfunction and acute onset, you should think of conditions like Guillain-Barré syndrome. It may be a chronic process which is causing sensory, motor, and also now autonomic dysfunction. It may be because of chronic conditions like diabetes mellitus or amyloidosis. And most of the time sensory, motor, and autonomic manifestations will be there in various combinations. Sometimes only autonomic problem may come. Like in GBS, only autonomic neuropathy may be there, no sensory loss and no motor loss. So this type of manifestation may also come in some individuals. So as I mentioned, autonomic neuropathy, and neuropathy may be either acute onset or maybe chronic. Acute is seen condition like we see quite often, Guillain-Barré syndrome or porphyria. Sometimes it may be because of toxins or drugs like vincristine. But most of the time autonomic nervous system involvement will be still in polyneuropathy, which are of chronic duration, like diabetes mellitus, amyloid or paraneoplastic, or some hereditary neuropathies. As I mentioned, polyneuropathy means involvement of sensory, motor and autonomic fibers. Sometimes it may be predominantly sensory. Predominantly motor I have already mentioned. So polyneuropathy in which predominantly sensory involvement may be there in some individuals. So these are the conditions where the patient may have polyneuropathy but only involvement of the sensory nerves or predominantly sensory nerves. So diabetes can cause all sorts. It may cause sensory, motor, autonomic, various combination, or motor only or sensory all. And malignancy can also cause Sjogren syndrome or some dysproteinemia or vitamin deficiency or other forms or toxins. So they may cause predominantly sensory polyneuropathy. Sometimes what happens, there is involvement of peripheral nerves and it will cause loss of all sorts of sensation, whether it is touch, temperature, pain or joint sensation, etc. But in some patients with sensory polyneuropathy, some sensations are lost more than others. So usually all the sensory modalities will be affected, but sometimes there may be selective sensory loss. Not all the sensations are lost in peripheral neuropathy. So basically it depends upon the diameter of the nerves which are affected. So smaller diameter fibers which carry basically the temperature and pain sensation, they have got either no myelin sheath or very thin myelin sheath. So if a patient has got demyelinating disorders causing sensory nerve involvement, so temperature and pain fibers may not be affected. As a result, pain and temperature may be preserved, while other sensations like touch or vibration and position may be affected more severely. So other way around also, there are some neuropathy which affect predominantly the small fibers, like the fibers which carry temperature and pain. In that situation, what will happen? The patient will have loss of pain and temperature, but other sensations may be preserved. So as a result, the patient will have a normal deep tendon reflexes, the balance will be normal and motor strength will be normal, because these functions are served by those nerve fibers which are having myelin sheath, which are thick fibers. So thin fibers carry temperature and pain. So if a disease process is affecting only the small fibers, so pain and temperature may be lost, while other neurological functions may be preserved. So these are the examples where the patient may have predominantly small fiber involvement causing mostly loss of temperature and pain, while other functions of the peripheral nervous system may be normal. It may be seen sometime in diabetes mellitus causing only smaller nerve fiber involvement, or sometimes amyloid. Some infections like HIV can also cause, and certain other disorders can also affect predominantly small fibers causing temperature and pain loss without other involvement. Other way around, some disease process affects predominantly the large fibers, sensory fibers. Okay, in that what will happen? Those fibers which are carrying sensation like touch or vibration or position, they will be affected, but the small fibers like temperature and pain carrying fibers will not be affected. So here the manifestation will be reversed, because the muscle motor power, deep tendon reflexes and sensory position, etc., they depend upon large fibers. So whenever there is involvement of the large fibers, the patient will have loss of deep tendon reflexes. There may be some muscle power loss also, and patient will have sensory ataxia. And Romberg signs may also come because of the loss of sensation going through the large fibers from the tendon, muscle and joint. So sensory ataxia neuropathy basically large fiber neuropathy may be seen in various conditions. It may be a manifestation of paraneoplastic neuropathy because of the malignancy somewhere, or patient may have some autoimmune disorders like Sjogren. Sometimes it may be because of toxins or drugs like cisplatin or excess of vitamin B6. Sometimes it may be immune mediated. Occasionally it may be a demyelinating disorders affecting mostly the thick fibers like GBS. So these are basically examples where the involvement is predominantly of the large fiber or thick fibers. In some individuals who have got peripheral nerve involvement, there is enlargement or hypertrophy of the peripheral nerves because of the disease process. So this enlargement of the peripheral nerves may be involvement of only one nerve, or it may be generalized or at multiple sites. So that will give you idea about the underlying etiology or pathology which is responsible for the neuropathy. Like if there is a single nerve involvement, like if you see the greater auricular nerve here, there is significant enlargement. This is basically a peripheral nerve. So it is only one. So when there is only one nerve is involved, you should think of one type of disorder. If multiple nerves or there is generalized peripheral nerve involvement in the form of hypertrophy, you should think of other possibilities. So if it is localized, it may be a local pathology like neurofibroma may be there, schwannoma may be there, or some malignant local lesion may be there, or metastasis may be there. So in that case, a localized enlargement of one nerve will be there. Sometimes patient may have generalized or multiple sites of nerve hypertrophy. Like in leprosy, it may affect the upper limb, it may affect the lower limb, or in neurofibromatosis also, there may be multiple nerves which may have thickening. And inherited disorders like Charcot-Marie-Tooth will have enlargement of nerves both in the upper limb, lower limb, neck, etc. So you should see whether the nerve enlargement is focal only, or only one, or multiple. That will give you some idea about the underlying etiology. Similarly, the patient who have got some neurological disorder, they may have some abnormalities on examination of the skin and appendages. That will give some clue about the underlying etiology. Like if a patient has got purpura or livedo reticularis, it might be neuropathy because of vasculitis. Or purpura may be seen in other conditions like cryoglobulinemia. So basically, or if the patient has got some skin pigmentation abnormalities like hypopigmentation is there and peripheral neuropathy is there, you may think of leprosy. Or sometimes it may be other way around. The pigmentation may be more than normal, which may be seen in conditions like Poem syndrome. So basically, skin lesion can give you some idea. If a patient has got Meche line, for example, and peripheral neuropathy is also there, you should think of conditions like arsenic poisoning or thallium poisoning. So clinical examination of the skin or appendages can give you some clue about the underlying etiology which is responsible for peripheral neuropathy. So after that, you have to do a special test to find out what we are dealing with. So you have to carry out electrodiagnostic studies. So what are the advantages or what are the role of electrodiagnostic studies in patients with peripheral nerve involvement? Firstly, if you do the NCV, etc., it will confirm that neuropathy is there or not. Okay, and it will also tell you which nerve is affected. Median nerve is affected, or ulnar is affected, or common peroneal is affected. So it will locate the site of lesion. And also it will tell you what type of neuropathy is there, whether it is demyelination or eczema, and also how severe it is, and also clinical course. You can repeat the NCV after some time to see whether the pathology or the nerve dysfunction is improving or worsening. So, but the problem with the electrodiagnostic modalities is that they do not evaluate all the nerves fibers. They basically evaluate the function of the large fibers, myelinated fibers, while the unmyelinated fibers or thin fibers are not evaluated by the NCV. So they cannot be picked up if they are abnormal. Suppose a patient has got only involvement of the pain and temperature carrying fibers, then NCV may not detect that abnormality. So that is a limitation. So in case the patient has got involvement of the unmyelinated fibers or thin fibers, then how do we make the diagnosis? Then you have to take the help of other special tests. You can do quantitative sensory testing to see cold and heat pain threshold. That will give some idea. And also you can do pseudomotor function, because that function also depends upon the unmyelinated or thin fibers. And if that is also not working, you can do the skin biopsy to see that small fibers are normal or not. So you for unmyelinated fibers, you can just assess the skin for any abnormality of the sweating, or what you can do, what is called quantitative pseudomotor axon reflex test. That also is dependent upon the unmyelinated fibers, which are not detected by NCB. So other special test which can be done in nerve peripheral nerve involvement is skin biopsy. So as skin biopsy is especially important when the patient has got small fiber or unmyelinated nerve fiber involvement, because those fibers are not detected to be abnormal by the NCV. So it will be helpful in finding out involvement of the unmyelinated or small fibers. And especially this skin biopsy is important, useful when the electrodiagnostic tests like nerve conduction studies are normal. But if you do skin biopsy, it will just show that something is abnormal with the small fibers, but it does not give what is the specific etiology. So other tests which can be done is the nerve biopsy. So when other tests have not given you the diagnosis as for the etiology is concerned, then nerve biopsy can be carried out. So there are various nerves which can be subjected to nerve biopsy. One is commonest is the sural nerve. Other fibers, other nerves which can be used for nerve biopsy are the fibular nerve, or the cutaneous nerve of the thigh, or superficial branch of the radial nerve. But these days the nerve biopsies are not required in most of the patients, because you can make the diagnosis based on clinical evaluation, some blood investigation, electrodiagnostic evaluation, or in some cases of genetic tests. Like if we are dealing with the hereditary sensory motor neuropathy, then genetic tests can give you the clue about the underlying etiology. So nerve biopsies are not very commonly done. So basically there are certain situations where nerve biopsy may be done when the diagnosis is in doubt. So the condition where nerve biopsy may help is when a patient has got multiple nerve involvement and etiology is not clear, like vasculitis may be there, or infiltrative disorders may be there, some infections like Hansen may be there. Then you can take the help of nerve biopsy. Otherwise, if the diagnosis has been made based on other evaluations, then it is not required. So other tests which can be done, it depends on the clinical profile. So you have examined the patient, there is some suggestion of involvement of the peripheral nerves, electrodiagnostic studies have confirmed the involvement of peripheral nervous system. Then from the history and examination, find out what is the underlying etiology, whether it is some collagen vascular disorders or leprosy or some drugs, etc. And accordingly you have to carry out the laboratory tests which are relevant to a particular patient. Don't carry out all the investigations in every patient. Depending upon the clinical profile and other usual investigations, you have to select the specific tests which are going to help the patient you are dealing with. So, but in every patient of neuropathy, certain basic tests you can do in most of the patients. Like you do the blood count, ESR, and also do any dysfunction of the visceral organs is there or not, renal function problem is there or not, thyroid is normal or not, liver dysfunction is there or not, any evidence of some gammopathy is there or not, then you can do electrophoresis. So depending upon the clinical picture, you have to decide which test to be done. You don't have to do CSF examination in every patient. But when you have got a patient who has got peripheral nerve involvement and other features suggest of demyelination like GPS or CIDP, then CSF examination is helpful, not in all the patients. And other investigation which can be done in some patients with the peripheral neuropathy is the evaluation for autoantibodies. There are various diseases which affect the peripheral nerves as a complication. It may be collagen vascular disorders, it may be malignancy somewhere. So then you have, or maybe one some autoimmune this GPS type. So in selected patient you can carry out investigations for autoantibodies. So they are basically examples. I will not go into the details of different types of autoantibodies which may be detected in certain individuals. You don't have to do these tests in every patient. So patient, for example, in Guillain-Barré syndrome, sometime you will require this GQ1B autoantibody, not all the time. So depending on the clinical picture, you have to carry out these autoantibody evaluation, not all the patients. So with this, I come to the end of this discussion. I hope it must have helped you, and it will help you in evaluation of patients who have got some peripheral nerve involvement. And if you got any other query when we start your regular function, then you can have clarification about that. So with this I close the session. Thank you for